Yeah, thank you. Nigerian Society for Colorectal Disorders. We've been treating this topic on medical legal issues and the surgeon because the times we are in now are very delicate times. More people are getting aware of their rights as patients, and we have to practice within the confines of the medical ethics and also the law of the nation. So we cannot overemphasize this topic actually. And last month when we had Professor Osime talking on this topic, I think time constraint was a problem. And that is why we pleaded with him again that he should come and revisit the topic this month. And we are very grateful for his coming again to shed more light on this topic. Before I continue, I want to welcome one of our great teachers who is in the house, Professor Aderomu. You are welcome, sir. It's an honor having you around, Prof. You are welcome, sir. And I also want to tender apologies on behalf of Dr. Augustine Rotulam. He might not be able to join us today. So please, if you have any questions as the talk is going on, post your questions. At the end of the day, Dr. Eguare will sum them up and direct them to the presenter. I think Prof is going to have almost like 45 minutes to 1 hour today on questions and answers. But in the meantime, he wants to go through some case scenarios to enlighten us and educate us. So at this juncture, I want to welcome Professor Osimen. Professor Osimen is a consultant general surgeon, an oncologist by specialization. He's a professor of surgery at the University of Benin Teaching Hospital. He also doubles as a barrister at law, and I think he's a lawyer of the Supreme Court of Nigeria. So with all this experience, both from the medical field and from the legal background, I think there is no other person as at now that can do justice to this topic. Please permit me to welcome Professor Clement Osimen to deliver his talk on medical legal issues and what we are supposed to know as doctors and as surgeons in general. Thank you, Prof.
All right, thank you very much, Dr. Adejumo. I want to appreciate once more the leadership of the society for giving me the opportunity to talk with my colleagues. I do not take this for granted at all. It's a thing I love to do. So we start. Can they enable me to share my slide, please? Teddy, then make me a co-host so I can share my slide.
Okay, Dr. Ade, please can do that. Make Prof co-host so that I can share a screen.
Because I try to do that, it's telling me that, you know.
Yes, you are now the co-host, sir.
Okay, I've seen it now, that's fine. Okay. Okay, please. I will confirm you can see my slides.
Yes, we can see.
Okay, hold on. I'll try to put it on slideshow. Okay, so slideshow now you can see it.
Yes, sir. Yes, Prof.
Excellent. Okay, fine. So today we are continuing from where we actually stopped last time. I'll give a background. Somebody asked a question that what led to this. He asked me a question that, you know, the issue of foreign body I mentioned. He also give a background that the way I said it should be handled, he wanted to ask a question. Unfortunately, there wasn't enough time for him to ask that question. So I promised him I was going to call the president, Dr. Adejumo, to find out from him if we could discuss about that. It was so important that we shouldn't just let it go like that. Because that doctor that spoke to me is a very senior surgeon, but his approach was different from what I said at that meeting. So that prompted this second leg of the lecture. So, hold on. That's my outline I will be using for this. Again, I will mention a few slides, just like I did last time, for the benefit of those who are joining for the first time, because I spoke to a number of colleagues and they were quite excited. I remember we said that the era of a patient or relation, maybe if a patient is mismanaged, saying that, oh, that's the will of God, if there's a complication, or the doctor is very knowledgeable, that era is gone and may never come back again. Because our patients have become increasingly aware of their own rights, and therefore as surgeons, we must practice in such a way that we can avoid litigations. We also mentioned that a surgeon is somebody who specializes in evaluating and treating conditions that may require surgery. So we're going to be dealing with retained foreign bodies today. So we'll stop at that require surgery. We also mentioned that the best surgeon is that surgeon that knows when he shouldn't operate. I talked about some of the qualities of a good surgeon. I remember we talked about empathy, being able to empathize with the patient, being able to sympathize with the patient, being able to communicate effectively, also listen to patient talk to you. We said you should be humble, you should be humane. A surgeon should not be arrogant. But above all, honesty and integrity are key. Now, and I put it here, you may never know when you're in the OR, so that you watch what you do and what you say, your actions or inactions. The porter who willing the patient may just be a cousin of that patient. The nurse who's scrubbing for you may be a cousin to that patient. You may never know. So we have to be careful. Then what we call duty of care. What we are going to discuss is hinged on this. In thought, duty of care is a legal obligation that is levied on individual, requiring adherence to standard of reasonable care while performing any act that would possibly occasion harm to another when that harm is reasonably foreseeable. So if I'm using abdominal mop during my laparotomy, I already know that there's a possibility of forgetting that mop in the abdomen. That's what we call reasonably foreseeable. I know. Therefore, if I know that that is a possibility, I ought to take precaution so it doesn't happen at all. And remember, once you have taken up a duty to care for a patient, we said, whether it's free of charge, pro bono, ex gratia, or you're collecting a fee, the same standard of care must dominate what you are doing. So you must demonstrate reasonable standard of an ordinary surgeon who has requisite training in their field of surgery. We went on to say negligence is that failure, therefore, to exercise the standard of care that somebody who is reasonable and prudent would have exercised working under the same circumstance. You are going to see some defenses that may come up. Maybe you operated somebody who was bleeding profusely, you're using mops and all that, or maybe the generator went off. They tried to put on the inverter, it went off. Things like that. If that were to happen and the facts are laid open in the court, somebody can say, under the circumstance, maybe the doctor was rattled, anybody could have made that mistake. So the circumstances are quite important also. Now you are expected to act in compliance with the standard accepted by a responsible body of surgeons that are skilled in the art of surgery. What is the standard? For example, after a procedure, there ought to be swab and instrument count. That is standard. Now, once you deviate from that swab and instrument count, which is the standard practice, then there's already room to establish a case of negligence or malpractice against that surgeon. Now, we're going to zero down on surgical errors. Remember last time we talked about a number of surgical errors. Retaining foreign body or leaving foreign body behind the abdomen or any organ, for example, falls under surgical error. We should define that as the failure of a management protocol to be completed as planned. You didn't plan to leave an abdominal mop inside the abdomen, or the use of a wrong management plan. Potential surgical errors can be litigated to establish negligence. Once, we're going to see later what we call the doctrine of res ipsa loquitur. The fact speaks for itself. We're going to see it. That in issue of malpractice suits, oftentimes we say, let the plaintiff prove. This is an exception to the rule, if you like, that if you have left an abdominal mop in the abdomen of a patient, the issue of saying the plaintiff should prove doesn't really arise. The onus is now you, the defendant, the surgeon, to show to the courts that you were negligent. The surgical errors is not a local problem at all. So that we shouldn't be terrified. It's not a local problem, but we must be careful. Over 200 million surgical procedures are performed each year globally. And despite awareness of adverse effects, surgical errors continue to occur at very high rates. Surgical error accounts for a significant number of adverse events. At least about 4,000 surgical errors occur each year in the United States alone. Leaving a foreign body is a common source of surgical error. So this is a list of common surgical errors. I highlighted the one we are taking today: surgical instruments, abdominal mob left in the abdomen. Routine foreign body. Some people refer to it as gossipiboma, from Latin word gossipum, cutting, and kishwali boma, or place of concealment, or retained surgical spawn. Is a ubiquitous medical error that is avoidable. That is the word, avoidable. The retained sponges were first referred to as teslomas, but were later renamed gossipiboma in 1978. They are rarely documented. We are coming to our point of discussion now. They are rarely documented, owing to medical, legal, and other reasons. You may have your reason why you don't have to document it. Like I said, that was what prompted this second leg of the lecture. A colleague said, no, he won't document it. Literature says show that the reported foreign bodies retained in the abdominal cavity will include several other things, like sponges, towels, artery forceps, and etc. Retained surgical spawn occurs at a frequency of about 1 per 100 to 3,000 operations. The three most significant risk factors, we are looking at risk factors where you should be careful when you operate as a surgeon: emergency situations, or planned change in the operation at the crew. You've done an operation, I'm going to go for school run. Please, Mr. B, come and assist me. My wife travel, I'm going for school run. Or planned change, you didn't tell the person before. It just comes in. You might have left him up under the liver. He didn't know, it wasn't there. You know, and body mass index. But very obese patients, the risk of forgetting things is quite high. Now, when things are forgotten in the abdomen, especially abdominal mob, it may come in an acute phase or chronic after some months or even years. Now, there are some only questions we may want to ask ourselves. We have established that the potential error is very high. Now, due to the cost control measures, maybe in terms of staffing, equipment, and all that, are individuals to be held accountable? There are some only questions. Or is increased workload, like we're having now? Many people are leaving the country to go overseas, leaving behind few surgeons. Is increased workload and staff fatigue, will it offer a surgeon a defense if you're to forget abdominal mobs? Why do you need to report it at all if it happens? Failure to report errors may subject clinicians to disciplinary actions and increase the risk for legal liability. Whereas if you report it, the risk is less. Beneficence and non-malfeasance are ethical concepts that are violated when an error is concealed. Now, why do practitioners not report it? They often fear they will get a negative reputation for committing mistakes and they may not want to self-report. They know that mistakes and written warnings are often documented in personnel files, and they don't want that. It may impact on promotion, may impact on some allowances and all that. Now, does the system need modification to decrease the penalty and encourage reporting? There are some questions. At the end, I can see that Aderomo, my teacher, will brainstorm and answer together. Now, what are the consequences of surgical errors? I've left abdominal mob and it was discovered. What are the consequences? Healthcare professionals experience profound psychological effects such as anger, guilt feelings, they feel inadequate. Some are depressed, and some people even have suicidal tendencies. Because you can become the talk of the hospital. Now, why for Dr. A? Maybe if it's happening for the second time. Now, only in days, anytime you operate, you forget something. Last time you forgot abdominal mob. This time you forgot scissors. The threat of repeating legal action may actually compound these feelings. The people will say, we'll go to court, and the doctor is finished. Will the hospital support me? What will happen to me? Now, the surgeon is therefore placed in a dilemma when findings are detected. Does he concede information? That's a dilemma. Or will he give out the information? It's even more confusing if he was the one that did the initial operation. The scenario is not quite the same if Dr. A did the operation and Dr. B now operated, found the abdominal mob. It's probably even less challenging. It's more challenging if Dr. A did the initial operation. Dr. A is the one that opened the abdomen when the patient came with complaints and found the abdominal mob. The tendency to want to conceal it is higher here. If you found it, somebody did the case, oh yes, it's easy to report. Assuming you're the one who did the initial operation, will you be willing to report that this was the finding you saw when you went back? So that brings us to the question, therefore. Did I tell or I shouldn't tell what I found in the abdomen? Somebody did a study, Borolini et al., when he presented a series of 4,547 cases of retained foreign bodies. Remember I said MOPS, textile materials, are more. And 90% of that was from MOPS. They found that 74% of surgeons will not tell the patient about the removal of a foreign body. So it's not only that my friend who was arguing with me, led by another colleague, 74%. You can imagine this percentage will almost be 100% if you are the one that left the foreign body behind after the initial operation. Therefore, so paradigms need to be broken in order to better understand this phenomenon, to encourage people to report. They therefore opine at the end of that paper that retained foreign body should be approached as a systemic failure, not the surgeon's failure as it were. No, so not as a product of negligence or incompetence of a professional, except of course, when that surgeon or professional has been found to be notorious for being reckless. Now, retained abdominal mob. Questions again we are going to answer at the end. Can the surgeon doctor the operation notes? What that means is you open the abdomen, you found a big abdominal towel. When you're writing operation note, we normally write name of surgeon, Dr. A, assistant, Dr. B, nurse, this. We now go to intraoperative findings. Are you going to exclude the abdominal mob? Again, that my friend said on 2 occasions, they have found mob led by colleagues. In order to protect the colleagues, he didn't make measure of the mobs at all. At the end, we're going to brainstorm on this. Well, that is action correct or not correct? Now, when a patient asks for the intraop findings, some patients are very knowledgeable. So during ward round, second day post-op, he said, doctor, thank you for the operation. I feel better now. What exactly did you find in my abdomen, sir? What would be your response to that patient? Under the circumstance that your colleague did initial surgery or you did initial surgery, will your attitude or posture be different or will be the same? You ask yourself at the end, particularly if it was your colleague that did the operation, who are you protecting by not reporting? Are you protecting yourself? Are you protecting the patient? Or you are protecting your colleague? But I believe the surgeon should open up. To that extent, governmental, legal, medical institutions must work together as a unit to remove the culture of blame while retaining accountability. Before we started, Brother Guare talked about accountability, retaining accountability. While you correct people and all that, we must retain accountability. Preventable medical errors contribute substantially to healthcare costs, including higher health insurance costs per person expenses. Only by health professionals working together as a unit with the cost of an injury associated with medical errors be mitigated. Now we're looking at surgical errors, the compensations. It could potentially lead to malpractice claims. Then the world is now a small village, which you mentioned the other time. The world is a small village now. We need to do all we can to avoid litigations. The last point I put there, the attitude of surgeons will go a long way in determining whether there will be litigation or not. You are going to see a case, one of the cases I'm going to present just now. But there's need for us to do root cause analysis with regard to surgical errors. Because it's designed to help discover the causes of errors and get to the source of it. It is intended to discover the hidden cause or causes of an error. What are the reasons? Individuals on the root analysis team focus primarily on systems and processes, not merely on the action of the individual. It should lead to action plans that include strategies that will identify and reduce the risk of future similar events. Because safety of the patient is our goal as doctors, reporting therefore should be encouraged. And I believe I allow myself with this thought. Information from reports should be shared and published across the entire organization to prevent future errors. And I have a quotation I put here. When you've gotten the facts and figures right, you've gotten your data, generate light with your data, not heat. Light with your data means you are showing the pathway to avoid future occurrences. But generating heat, you are punishing the person that was involved. You malign the person, you run him down. Other person will be afraid to report if they find such things. So generate light with your data and not heat. There are some common causes if you are going to do root cause analysis. Lack of adequate training for the surgeon, absence of standardized rules and regulations, major gap in communication is key between the surgeon, nurses, anesthesiologists, and other auxiliary staff. Change of crew in between surgery. One of the cases I will highlight is exactly what happened. A very dutiful surgeon did a hysterectomy. He was called to the other room to come and assist. He had an emergency. He left. Senior registrar complete the operation. That's how that case happened. We'll discuss it shortly. Change of crew. You must be careful. We are taking over from your colleagues. You may need to ask some few questions. They might tell you, I'm rushing for school run. Ask a few questions before you take over. Very important. Use of unreliable systems or protocols. Being over familiar with protocols and processes. When they are counting instruments, say, no, let's go, not today here, not today here, let's close. They are too familiar with processes. You should be discouraged. Follow, you're like pilots. They never get too familiar. They must go through the processes before you take off to fly. Rush to complete cases. So to a reason, you want to rush. But that may be a reason for a different debate. Assuming the theater is very hot, you are sweating to your pants, you are feeling dizzy, you are rushing to complete the operation. Would that offer you a defense? At the end, we'll look at all that. Human factors, of course, shortage of manpower. That happens a lot. You are operating, the scrub nurse is the one counting instruments alone, no scrub nurse. It counts alone. It's bound to make errors. Inappropriate staffing, poor facilities, like I talked about AC, poor lighting, and all that. How do we prevent surgical errors? Adopt a checklist. Instrument and so should be counted before and after. I put it here, there must be a circulating nurse. And I say, for example, you can say as a surgeon, if there's no circulating nurse, I will not start this operation. Continuous medical training to ensure strict adherence and surgical rules. Use of sponges or instrument with radiopaque markers. I put question mark there. It may be actually like medicine after death. If you use radiopaque thing, you take abdominal X-ray, it only show you there's the abdominal mob. It does not really cure the defect. There's a problem there. Use of drain fixing switch-offs for drains that may be lost into the abdominal cavity. Performance of routine post-operative wound and cavity exploration. My dear surgeons, I will advocate that you adopt this method. My residents, if someone here, they know what I do. When the nurses have counted, swab and instrument complete. Every crevice, whoever placed a mop or a gauze, I use finger to check those crevices. I never forget it. They have counted. Oh, beautiful. It's a double check for me. I think we can adopt this. They've counted, because they are human beings, they can make mistakes. So by the time you add this bit of extra, and people recommend this, you do performance or routine post-op wound and cavity exploration before closure, irrespective of the fact that they've told you that the count was complete. Avoidance of shifting during operation where possible. Except if maybe somebody is collapsing. The person that started operation should try to finish his operation. The idea of calling your colleagues to come and complete it, you can make some mistakes like leaving. The digital checklist, you are familiar with this, we'll just skip that. Compensation for the patient, yes. I'm aware we may have some chief executives here, some MDs, CMDs maybe here. When a mob have been retained or foreign body retained and have been discovered, we must find a way to refund some monies or a bill reduction, reduce the bill for the patient. There should be compensation of damages for any harm caused as a result of the doctor's misconduct or negligence. We need to retrieve the medical records on patients' behalf. I want to see the details. There should be an explanation from the doctor or the healthcare institution in respect of a treatment or procedure, what was done and the outcome and the possible expectation. Then there should be an order that the doctors perform a particular procedure or offer a certain treatment to make good this defect. Then there may be a need for the doctor to apologize to the patient. The health institution management can also apologize. It may lead to a situation where the license of the doctor is revoked, particularly when he was found to be reckless. And the institution itself can also face some litigation. There may be criminal sanctions. Remember last time we talked about criminal sanctions? When the doctor has been found to be reckless, there may be criminal sanctions either against him as a person or against the institution. Remember I talked about retained abdominal mob and the doctrine of res ipsa loquitur. Res ipsa loquitur means the fact speaks for itself. This was demonstrated in the case of Doxwell and Bethesda M Hospital, in 2017, where it was concluded that negligence per se, under this circumstance, that is normally, like I said, a plaintiff, like the patient in this case, has the onus to prove that you were negligent. However, retained foreign body is an exception to this rule. If you left abdominal mob in the abdomen, patient be having pain, they now open up. Patient has never had surgery before, but only the CS he had with you, and he had this mob retained. I mean, the fact for itself, it's not left for you as a surgeon to prove that you are not negligent. Then the doctrine of vicarious liability. Remember we said that you as a consultant, the patient is registered under you, you are under the hospital. When the mob is retained in the abdomen, the surgeon that did the operation, the consultant, and the hospital will have questions to answer. Can I really be sued? The answer is yes. Remember we said, if it can happen at all, it can happen at any time. It will most likely happen when you least expect it. When the problem arises, I've forgotten the mop in the abdomen. What should I do? I've said again, try to avoid leaving a mop at all in the abdomen. That's the best. But if it has happened, you left a mop, be honest. Do not doctor the operation note. Do not tell lies. Don't conceal information. And according to the work of FEMA, published in British Medical Journal 209, learn to say, I'm sorry, and learn to adopt alternative dispute resolution. So we run through 4 cases. One is a reported case. In this case, Olabisi Onewajo, it was a case that had an abdominal surgery by a gynecologist who left an abdominal mob in the abdomen. And the victim went to medical counsel, and the doctor was found to be negligent for leaving a mob. He was suspended from practice for 6 months. Now, these are local cases. I want to share the way I manage it, then people will not make their contribution. Today's discussion, it's not going to be much of talk. We have room for discussions. The first case, Mrs. E.O. was a 47-year-old lady that had a cesarean section some 2 years before presentation. She now had the right sudden low abdominal pain that had been recurrent. The doctor that saw made an assessment of acute appendicitis. At surgery, of course, that took almost 6 hours, they were looking, they discovered that it was abdominal mob that fistulated through the cecum, actually going through now the ascending colon. So the surgeon called the senior brother of the patient to the theater. So he was called to the ORO, and the findings explained to him. Pictures were taken not by the patient or relation, not by the relation, by the team, so we were a team in the theater. The patient subsequently had a right hemicolectomy and iliotrabecular anastomosis after removing the abdominal mob. The surgeon that performed the first surgery was duly notified that same day that this patient did a CSE or facility. The surgeon and top management team from our hospital, they behaved in a very responsible manner. They made several visits to the hospital to apologize and sympathize with this patient for the pain and agony they caused her. They even offered to pay the hospital bills to this second hospital where the mop was removed. But the patient and relation felt that wasn't necessary. They didn't need that. The brother had even given assurances that there wouldn't be any litigations. This patient made uneventful recovery and was discharged. A week after discharge, the patient lawyer wrote to the hospital where the CS was done and had intention to go to court. They were shocked. We were able to facilitate an alternative dispute resolution where we eventually settled for 2.8 million, big money. This is about 6 years ago now. So the chairman of that board, I appealed to him and said, well, pay this money. But when they were trying to be unreasonable, say no, the minimum they would take is 5 million. And the hospital said they could rate 2.8. And I told them, well, 2.8 to me is reasonable. If they say no, let them go to court. Well, when they now saw they took that posture of 2.8, that what we can raise, eventually took the 2.8 million. I'll leave that case for us to discuss further at the end. Second case, Mrs. RO was a 57-year-old lady that had a total abdominal hysterectomy plus bilateral saphenophorectomy. Few months after surgery, she had recurrent abdominal pain with fever. Abdominal ultrasound score done gave features suggestive of rotated abdominal mold. This patient went back to the first surgeon. The patient claimed in her words that she was not impressed with the level of attention she was getting from the surgeon. That was what eventually brought her to see me. So at laparotomy, we found a huge abdominal mold that has caused some small boy fistula with contamination of the peritoneal cavity. The doctor again, in this circumstance, was called into the theater. Findings explained to her. Pictures were taken by the team in the theater. Patient has small bowel recession and anastomosis, and after removing the mold. A day after surgery, I called for the relation of this patient. So I called a meeting, the doctor now, who was in theater, and some member of the family came. They promised there won't be litigation, but they were very angry, very furious. So the first surgeon was willing to come. Let me come and explain. I called him to come and apologize. I know what happened. He told me the story when he found the case note. I told him not to come because they were very furious, very angry. Because I couldn't guarantee that they won't attack him. About a week after discharge, patient did well, he wrote a letter of an intention to go to court for the pain and distress that patient had to pass through, and also because of the poor attention received, according to them, from the first surgeon. When they came back, remember when I was talking, I talked about the attitude of surgeon can determine whether a case will go for litigation or not. Then a meeting was then facilitated by me. Incidentally, the daughter attends my church. It was easy for me to facilitate the meeting. At this time, the first surgeon was invited because the anger level had calmed down. After a prolonged discussion, they requested that the first surgeon should pay. They had come down, they were not really angry to come and pay all damages. So, okay, pay this 300,000 that was paid for the hospital expenses and pay additional 100,000 to cover investigations, scan, beverages. You know, everybody say we were taking milk and all that to recover fast, and transportation and all that. We get to 400,000. The beautiful thing about this, the scrub nurse and the surgeon agreed to pay that 400,000 equal installment to 200,000. But again, for me, the surgeon being my very good friend, I said, don't worry, guy, I will support you with 100,000. So I paid 100,000. The surgeon paid 100,000. The theater nurse paid 200,000. The last case I will discuss before we go to discussion, Master IM. This is a very recent case. It was I think December last year. No, not December, I think June last year or so. Was an 11-year-old patient. Had been having recurrent abdominal pain for about a year. Had appendectomy about a year earlier. Within 1 year post-appendectomy, he had several hospital visits for this same abdominal pain, for which he had 3 hospital admissions. Each time he was admitted, he was managed as a case of adhesive bowel obstruction. He will respond. He will go home on those 2 occasions. Unfortunately, this 3rd admission, those non-operative management were successful. necessitating surgery. At laparotomy, a piece of surgical gauze, small gauze, was found. The omentum and some loose of bowel were all mounted around that piece of gauze. When that was found, I did the surgery. I called the father into the ORO, explained the findings to him. I took pictures. The man expectedly was very angry, very furious, understandably. After surgery, I went to meet both parents. They saw the boy, they were happy. The agitation had calmed down a little bit, but they were still very angry. So I pleaded with him, do you have the doctor's phone number that did the appendectomy? He said, yes. I found that it was like their family doctor back home in their state. I won't mention the state. I said, okay, give me the phone number. I got the phone number and I called the doctor, told him what happened. I said, what do you do? Call these people and apologize to them. He did that. After that, I had several other meetings. Of course, they told me following the doctor had called us. By the fourth meeting, the patient had made very good recovery. At that time, the boy had no more pain, moving about, eating and all that. The level of anger had come down. Do you know the family of this young boy ended up being my very good family friend? And last December, they organized a dinner where they invited me and my family to come and have dinner with them. Then the man concluded this, say, Professor, you are a good person. You didn't want to embarrass your colleague. The conclusion, where a hierarchy-based relationship exists, the main surgeon is liable. That's what I call the doctrine of vicarious liability for any preventable, avoidable adverse event provoked by the nursing staff as a consequence of the objective responsibility. People ask the question that day, not supposed to count, you are the surgeon. That is the funny thing. There's a principle they call the corpora in erigendo and corpora in vigilando. That is post selection and post supervision. You are the surgeon. If you notice a nurse is reckless, she's responsible, you are the right to say, no, this nurse cannot scrub for me. But if you ignore it, that will bother on post selection. And if you also discover they are not counting, they're not following the rules of engagement in the ORO, and you don't speak up to say, where is the scrub nurse? I mean, where is the circulating nurse to count for you? Then that would call lack of supervision. As humans, errors are bound to occur as part of human frailty. However, we must minimize chances of HIV surgical errors. However, when they do occur, honesty must be the watchword for the surgeon. There's no room for you to play a smart one. No, none of us here, after listening to this talk, should be caught in the web of doing the wrong thing while seeking to protect his or her colleague. The price, if you are caught in this web, may be too high a price to pay. And I'll end this presentation by quoting the words of Judge Patton when he said, we have collected all the facts and analyzed the fears involved and made your decision. I need to report this case. Turn off all your fears and go ahead and do what you need to do. Thank you for listening.